All right, let's dive straight into this explainer and arm you with the absolute essential high-yield diagnostic markers for HTLV1. If you're prepping for your medical boards, you already know retroviruses are a massive target for examiners. So today, we're zeroing in entirely on HTLV1. We're stripping away all the extra fluff and giving you exactly what you need to recognize those tricky clinical vignettes and absolutely crush the classic examiner traps. We've got a quick roadmap today. First, retrovirus core fundamentals. Then, HTLV1 biology and transmission. After that, we'll break down ATL, which is adult T-cell leukemia, followed by HAM, the inflammatory myelopathy. And we'll wrap it all up with the ultimate exam traps. Let's get right to it.
Part 1, Retrovirus Core Fundamentals. Let's lay the absolute baseline rules that test makers expect you to know cold.
Okay, so the absolute game changer here is step 3. First, the RNA genome gets reverse transcribed into proviral DNA. Then, the integrase enzyme physically inserts that DNA right into the host genome. And unlike other viruses that might just hang around in the cytoplasm or act as episomes, this proviral integration is completely permanent, meaning once a cell is infected, it is infected for the rest of its life. Also, keep this distinction in your back pocket. Most retroviruses actually need the host cell to be actively dividing to integrate. Lentiviruses, like HIV, are the famous exception since they can infect non-dividing cells. But remember, HTLV1 is a delta retrovirus, not a lentivirus.
You absolutely must remember that reverse transcriptase literally overturns the central dogma of biology, right? It flows backward from RNA to DNA. And its error-prone nature, specifically its total lack of proofreading capability, is a huge testing point. It's super sloppy, which leads to a massive mutation rate. That high mutation rate is exactly what drives all the antigenic variation and drug resistance we see across the entire retrovirus family.
Moving right along to Section 2, HTLV1 biology and transmission. Let's get into the specifics of our pathogen. Pay close attention to these geographic hotspots. If your question stem mentions a patient from southwestern Japan, like Okinawa, or maybe the Caribbean basin, your brain needs to immediately scream HTLV1. For cellular entry, it primarily targets CD4 plus T cells using the GLUT1 or glucose transporter 1 receptor. Now, transmission is fascinating here. The most common route for perinatal infection is breast milk, followed by sexual contact and then blood products. And this is a brilliant distinction. While HIV can transmit as a free-floating cell-free virus, HTLV1 strictly requires direct cell-to-cell contact to spread. Cell-free transmission for HTLV1, highly inefficient. Now, despite the severe diseases we're about to talk about, get this. It is highly testable that the cumulative lifetime risk for developing adult T-cell leukemia, or ATL, is only about 3%. For the neurological manifestation, HAM, it's about 4%. The vast majority of individuals who contract HTLV1, they just remain latent carriers for life, never expressing viral gene products or developing any disease. But for the unlucky few, the consequences are profound.
Which brings us to Section 3, ATL, Adult T-cell leukemia. Let's open the first of our 2 clinical folders.
When you read a question stem exactly like this, your examiner is practically begging you to see the pattern. Notice the demographics, a middle-aged male from an endemic region. Then look at the symptoms, hypercalcemia and lytic bone lesions. You might initially jump to multiple myeloma, right? But the key separator here is the presence of opportunistic fungal infections. That points directly toward an underlying T-cell immunodeficiency. Oh, and here's another massive clue test writers love to drop, a co-infection with the parasite Strongyloides stercoralis. It shares an endemic overlap with HTLV1 and actually promotes faster ATL development. These are your massive visual buzzwords that will light up your exam screen. ATL is a monoclonal neoplasm of CD4 plus T cells, and these malignant cells distinctively express CD25, which is the IL-2 receptor alpha. That acts as a crucial tumor marker. If they give you a peripheral blood smear, look closely for heavily lobulated or polylobulated nuclei that literally look like little flowers. As for the hypercalcemia, it's severe and multifactorial. The tumor cells secrete osteoclast activating factors like TNF-alpha, IL-1, and parathyroid hormone-related protein. The end result? Punched-out lytic bone lesions with absolutely zero osteoblastic or bone-building activity. Okay, listen up because this is a classic trap. Test makers will absolutely try to trick you into saying the TAX protein is present in the circulating tumor cells, but it's actually the HBZ protein that is universally expressed to hide from the immune system. Let's break that down. The TAX protein is a transcriptional activator. It hijacks host cell transcription factors to promote T-cell proliferation and block DNA repair. It is absolutely critical for the early transformation of the cell,
But because it is so highly immunogenic, the immune system will ruthlessly hunt down and destroy cells expressing TAX. So the tumor adapts. In vivo, ATL cells usually do not express TAX. Instead, they universally express the HBZ protein, which maintains that dangerous proliferative state without drawing any fire from the immune system.
Let's pivot to Section 4, HAM, the inflammatory myelopathy. This is the second major, but completely different, clinical face of the virus.
Put yourself in the test writer's shoes for a second. This clinical vignette is meticulously crafted to trick you into diagnosing multiple sclerosis. You have a progressive neurological decline, weakness and stiffness in the legs, bladder dysfunction, maybe some back pain. But notice the two key differentiators here. Cognitive function is usually perfectly preserved, and cranial nerve involvement is highly unusual. The high-yield takeaway here is the symmetric degeneration of those lateral columns driven by an autoimmune cross-reaction rather than direct viral transformation. This isn't a direct viral attack. It's friendly fire. Unlike ATL, which is a CD4+ cancer, HAM, also known as tropical spastic paraparesis, is an inflammatory infiltrate driven by CD8+ T cells. The pathophysiology is thought to be autoimmune. Your own T cells that are specific to the virus accidentally cross-react with neuronal antigens, causing myelin destruction in the spinal cord. Because this is an inflammatory process, acute episodes are actually treated with glucocorticoids. Antiretrovirals, they're not effective here.
If you only memorize one thing from this entire explainer, let it be this exact dichotomy. Locking down these comparisons will guarantee you those tough points. Look at the split. ATL is a CD4+ cancer that predominantly affects males, usually stems from perinatal breast milk transmission, and stews for an incredibly long latency period of 20 to 30 years. HAM, on the flip side, is a CD8+ autoimmune inflammation that predominantly affects females, is typically acquired later in life through sexual contact or contaminated blood, and has a much shorter median latency of just about 3.3 years.
Finally, Section 5, the ultimate exam traps. We've covered the pathology, now let's bulletproof your knowledge. Let's rapidly expose exactly how the question writers will try to misdirect you. Trap number 1, I literally cannot stress this enough, HTLV1 does not have its own oncogene. It transforms cells by using its TAX protein to hijack the host's own genes. Trap number 2, marker confusion. Always look for CD4 and the IL-2 receptor alpha, CD25. Trap number 3, transmission assumptions. Sure, HIV can transmit cell-free, but HTLV1 mandates direct cell-to-cell contact. And finally, trap number 4, the bone lesions in ATL are purely osteoclastic. If an answer choice even hints at osteoblastic or bone-building activity, cross it out immediately. Keep this exact diagnostic framework running in the back of your mind as you hit your question banks. Ask yourself, what delta retrovirus uses the GLUT1 receptor, requires cell-to-cell transmission, and presents two vastly different diseases depending on how it was contracted? Understanding this dual nature of HTLV1 is your golden ticket to unlocking the correct diagnosis every single time. Good luck with your prep, and go crush those exams.